Welcome to Living or Dying, a resource of selected readings and images to go along with the book.
Hello, I am Patricia Roach. I'm going to be making some comments and summaries from my chapter talking about pain, which is published in Living or Dying. And first of all, I note that pain is that unpleasant, unwanted, often traumatic experience that we have all had. We fear living in long-term pain, and we certainly fear dying in pain. Nevertheless, it's strange to realise that pain has rarely been talked about in medical literature in the past, except as a symptom of injury or disease. There is, however, much more to it than that. Demystifying and talking about pain can help individuals and their families to feel much more informed and in better control of pain. And my chapter looks specifically at acute and chronic pain. There is an appendix in the chapter which points to main sources of pain management in Scotland today. And the overall aim of the chapter is to help make pain more comprehensible and less fearful to the person who is living or dying with pain. So, what is it that would help to understand about pain in the first place? The first thing that we can certainly all understand and acknowledge is that pain is a hugely varied experience. It comes in many dimensions, comes in various causes, various different sensations, various severities, various durations, and various levels of threat to our daily comfort, to our work capacity and our long-term plans. It has hugely varied outcomes, consequences, and massively varied cures. And as we all know, it is hugely varied in the miseries it can cause. Since the mid-1970s, however, there has been a major shift in medical and scientific knowledge and clinical management of pain, which is to our advantage. The shift has provided much better understanding of what we call the body's pain mechanisms. By that I mean those interactions between painful sensation and our biological and psychological and emotional and behavioural responses to the sensation. And these interactions are in turn driven by very complex exchanges between the nerves, the spinal cord and the brain, and ultimately by the interpretation the brain makes of the complex information it receives on a moment-to-moment basis. So there has been, fortunately, the growth of pain management as a specialism in science and in clinicians and allied health professionals. And they have found it very helpful to define pains in terms of its duration. That is, whether it is acute, by which we mean it's relatively brief, or whether it is chronic, by which we mean that it's long-lasting pain. And it turns out that there are very important distinctions and differences between acute and chronic pain, which the listener may find very helpful to gain a better understanding of, and which is in fact is the focus of the discussions that I have made in my chapter. Now, briefly, acute pain refers to any pain that lasts less than 3 months, and chronic pain refers to any pain that endures longer than 3 months. And as it turns out, it's those terms that have allowed pain specialists to better understand the complexities of pain, and particularly chronic pain. For example, in terms of its long-term intrusion and its impact on a person's physical self, on their daily mobility, activities, their mental and emotional well-being, and even on a person's self-image. The pain specialists nowadays also take into account the wider detrimental effects that chronic pain can have on a person's cohesion with their own family and friends, on earning a living, on their overall well-being. These are all acknowledged and taken into a holistic perspective when viewing how to best manage pain, particularly chronic pain. And of course, because it is holistic, the contributing angles to a chronic pain situation, for example, incorporate medical and surgical and physical and psychological therapies, as well as pharmaceutical and non-medical therapies. So it's a comprehensive management approach. A better understanding of pain can help our capability to cope with it. The term acute pain, first of all, let's talk about that, includes those cuts, lumps and bumps typically experienced in childhood, as well as pain from a twisted ankle, from a fracture, even the very severe pain from an operation during adult years. Even the pain of labour is termed acute pain. It may be extremely severe, and of course it often is, but it is relatively short-lived, and that gives the meaning of acute pain. So acute pain can be of any intensity, mild to severe, but the pain normally recedes as healing occurs. That is within sometimes hours, within days, weeks, but certainly within 2 to 3 months at most. The important features of acute pain can perhaps best be understood by referring briefly to the experience of people who have been born without the ability or without the proper neural apparatus to feel pain, and that's called congenital insensitivity to pain. Now, these, mostly children, accumulate numerous and repeated injuries from everyday activities throughout their early years. They do not learn to avoid painful stimuli. They may drive sharp pencils through their cheek. They may walk on broken bones. They may repeatedly stick their fingers into a fire until the fingers are burned down to stubs. Their inability to feel pain also means that they have no means and no recognition of pain. They do not moan, they do not limp, they do not cry for help. and consequently they do not get any medical attention for their pain. And such cases have resulted in severe medical emergencies. For example, an infection following peritonitis can go unnoticed, either by the individual or by observers, and the result is a lack of medical help, which can certainly lead to an early death. Now, this sort of illustration lets us understand that pain, acute pain, is a warning signal. Acute pain allows us to pay attention to the pain. It allows us to even report the pain to a parent, to a doctor, and it allows us to proceed with healing behaviours for that pain. So that a sudden sensation of pain tells you that there is something wrong, and it also leads to healing pain behaviours. For example, to go to a physician to find out whether the sudden pain you have in your ankle is a sprain or a fracture. That allows the doctor to give you a diagnosis, whether it's a strain, a sprain or a fracture, and therefore whether you will be resting and off work for a day or two, for a week or two, or perhaps for months. And it also informs those around you whether adjustments are required to their normal daily routine, for example, to stay at home and care for you for the first few days. Or if you're an employer, whether to expect you to be off work for quite some time and whether to redistribute your workload until you return to work. So the important part about acute pain is that it draws attention to the fact that there is an injury, makes you perform illness behaviours which lead to a diagnosis. The diagnosis itself allows you to settle down your anxiety about the meaning of the injury and replace that with order and planning for the next steps in your recovery. And your recovery may well involve taking time off work, resting, taking pain-relieving medications until you are relatively pain-free and you can walk again. Most importantly, pain behaviours are progressively discarded as healing occurs, and you can resume your normal weight-bearing activities without pain. You can start going back to work. Importantly, your partner and employer can also resume their normal routine. So the whole incident of an acute pain injury often causes a mild crisis in the family and the workplace, but it is a relatively temporary crisis as long as healing occurs and the pain recedes as expected. And of course, it's also taught one to steer clear of the incident which led to the injury in the first place, so that you avoid having another disruptive period of intrusion and pain in one's life. So what we're saying is that pain behaviours and the empathy and helpful reactions that they elicit from physicians, employers and family are entirely appropriate to sudden injury, which is signalled by acute pain. In fact, all of society is geared to acknowledge and accept that your pain and injury are valid, and that temporary adjustments are required until you have healed and you can resume normal duties. Although intrusive and unpleasant, the relatively short duration of episodes of acute pain and of acute pain behaviours are therefore principal aids to human welfare and survival. And in fact, all of our medical systems are very, very well geared to dealing with acute pain and its healing. Take, for example, most of inpatients into a hospital are there with some type of an acute pain. Our medical training, our doctors and nurses and health therapists are very acute, very finely tuned in to dealing with people with acute pain. So let's go on to talk about chronic pain. Doesn't seem to have the same benefits. The person who is living with or dying with chronic pain really confronts very different situations and responses. Whether continuous or intermittent, chronic pain endures and intrudes into a person's life for months or years, and in some conditions for decades. People of all ages are prone to chronic pain, perhaps as a result of a deformity, sometimes from chronic headache, from nerve damage, from tumour, from gastrointestinal problems, chronic pain from the likes of arthritic conditions, diabetes, heart disease become more common from middle age onwards, and chronic pain following surgery or following invasive treatment for cancer is not uncommon. Cocktails of medications and their side effects also come often with their own problems, and that can include giving rise to chronic pain. And pain, which is clinically described as neuropathic, originates from some damage to the nervous system. For example, in trigeminal neuralgia, following a bout of shingles, which is quite common in older years. We should also understand that some chronic pains are totally bizarre in their presentation and may stretch the credibility of that pain in other people's eyes if they do not understand that some pains have a very bizarre presentation. You may have heard of phantom limb pain, whereby people with amputated limb might feel chronic pain in the absent phantom limb for years following amputation. Neuropathic pains can give stabbing or burning attacks of pain months or years after a nerve injury has completely healed. There is a lot of very sophisticated research has gone into a better understanding of the pain systems. We do know that the reactivity of cells in the spinal cord and brain sometimes go through several adjustments, and that can happen long after healing. And these adjustments can trigger, for example, continuous loops of pain messages being registered in the brain. And there's a couple of good analogies for that. One being, it's almost like an orchestra that's become stuck in its groove and is unable to stop playing the same tune over and over again. So this is where we're talking about a chronic pain arising long after an injury has actually healed in the body, but it is the internal pain system which has become somewhat adjusted so that, for example, it keeps reverberating the same sort of message that registers as pain. Also, the nerve responsible for transmitting the message of pain can become very oversensitized, and it means that they register pain even to very mild and usually non-painful stimulus. And you could think of that in terms of like being a faulty car alarm that goes off when a leaf falls on it. So the whole system of pain perception and pain transmission has become so hypersensitized that it registers pain a great deal of the time when there's no actual ongoing or new injury happening. It's difficult for people who develop one of these conditions because the standard clinical tests such as X-ray or MRI do not register and are pain of this sort, and are not helpful in diagnosing problems as they could be and would be in explaining the reasons for an acute pain, which can show evidence of an injury or disease. And patients with chronic pain sent for these clinical tests understandably can expect a result which explains their pain, and they find it alarming and bewildering if the doctor then tells them that the results are negative and there's no clinical reason for their ongoing pain. And of course, the added complication in chronic pain is that it is chronic precisely because it is fairly resistant to normal pain medications and pain treatments that are effective for acute pain. So all of this simply underlines that chronic pain is a very complex situation. It is difficult to understand and to diagnose, and it's certainly difficult to treat. And despite this, research consistently shows that 1 in every 5 people in the United Kingdom lives in chronic pain. That figure is very, very similar to the number of people living in chronic pain in all European countries. So it underlines the actual enormity of the problem. And yet we have to remember that historically our medical systems and have not been geared towards either understanding or being able to treat chronic pain very well. So this might be a good time to point out that we have a better understanding now of how these complex situations affect the well-being of the person who is living in chronic pain. And by its very nature, the main characteristic of chronic pain, that is, it's a very long-term enduring pain, it reflects the fact that those protective pain behaviours or healing pain behaviours, which are appropriate to helping to heal an injury which is causing acute pain, such as resting and taking pain medications, tend not to reduce chronic pain. They don't heal, they don't restore the individual to normal pain-free activities. And as a consequence, the individual with chronic pain can feel trapped in pain and helpless to avoid its long-term effects on his or her quality of life. And another feature of chronic pain is that those clinical signs and pain behaviour that are characteristic of acute injury and acute pain, such as inflammation, moaning, groaning, using crutches, usually fade over time in the person with chronic pain to give an appearance of normality. Part of that is because a person with chronic pain very quickly learns that continuing to report their pain, which is sometimes a bit non-understandable to the layperson and even to some medical personnel, that continuing to report that again and again when there seems to be no appropriate clinical signs to explain the pain can often lead to a sense of skepticism from their observers or even from their medical personnel. So that to observers, the person may appear to be pain-free, but he or she is in fact still in pain that is invisible to others. This is not quite the case with all people with chronic pain. The person with a clear diagnosis for chronic pain, such as rheumatoid arthritis or cancer, does have a diagnostic validation for the longevity of their pain. Everyone can still understand why the pain still exists. Therefore, empathy, regular health appointments and care continue to be freely given. The person with an ambiguous or absent medical diagnosis for chronic pain is at risk of losing similar acceptances and provision of care. Some forms of abdominal pain, limb pain, back pain and nerve pain do challenge the traditional physician's diagnostic skills and comprehension. Now, this can lead to the person who understandably, repeatedly presents to a doctor with these complaints saying, look, my pain is still there, can be at risk of being clinically labelled with a psychosomatic pain, especially if clinical tests have already been exhausted and are only giving negative results. In fact, nowadays we can clearly say that it is in fact the physicians or the healthcare team's lack of familiarity with modern findings from pain science and consequently their adherence to very traditional views of pain that is the problem. But under these circumstances, the person in pain can really feel skepticism from others towards their report of pain and can encounter withdrawal and dwindling medical support from their health carers. Family and friends may also struggle to believe in and support the patient's pain. Now, under these sort of circumstances, strong feelings of bewilderment and isolation are common in addition to the usual stresses of having chronic pain. And a common response is for the individual in pain to go doctor shopping or to subconsciously exaggerate their pain behaviours, which, by the way, are simply a means of rather desperately trying to indicate to the world that they are in genuine pain and that they need some help. Or they may become angry or demanding when consulting healthcare providers. Now, it should be understood that such behaviours in a person with a chronic pain problem which is not being well diagnosed or well understood or well managed represents an entirely normal human psychological and behavioural response to continuing pain that is being met by scepticism by health providers and others. Now, Pain management in the UK, however, has developed over the last few decades into its own specialty. And the situation is better. For example, medical teams call upon the expertise of pain specialist anaesthetists for the control of post-surgical pain. The palliative care physician works together with the pain physician in the multidisciplinary team to manage distress, to relieve pain and overall suffering during end-of-life management. There are chronic pain services now set up throughout every health board in Scotland, England, Wales and Northern Ireland. They are structured quite similarly to the Scottish model, which is made up of 4 levels. Level 1 is self-management of chronic pain, which is linked with national charity services to the community, particularly a national charity service called Pain Concern. Level 2 of the Scottish chronic pain level is primary care, whereby the patient would feel it appropriate to make appointments with their GP and their allied health therapists to manage their chronic pain. Level 3 is secondary care, which is National Health Service multidisciplinary pain clinic services. And level 4 would involve visits into hospital, the highly specialised analgesic services. The 4 levels provide only reliable and evidence-based treatment and management strategies. And of course, people should be able to move between the levels based on the need. However, for a large majority of patients, good intervention at levels 1 and 2 should reduce or even remove the need to be referred for higher levels of pain management care. Now, pain clinics throughout Britain and pain specialists and those working for the national pain charities such as Pain Concern understand the detrimental effects of chronic pain on the individual and potentially on medication use, on the individual's work and family life. And they are able to provide useful information to address these kind of problems. For example, if chronic pain appears to become dominant and disruptive to family cohesion, and as chronic pain patients sometimes describe, and feels like an uninvited guest lodged in the home, there is information and advice on how to handle family dynamics in those sort of situations. There is information on medication management, getting the best out of consulting with health practitioners, getting the best out of discussing the situation with an employer, with workplace adjustments to support the employee's work output. Pain management staff also help with the management of flare-ups, and those are debilitating increases in pain intensity, often occurring following unaccustomed activity or additional emotional stress. Flare-ups are hugely common in chronic pain conditions, perhaps particularly in the musculoskeletal and neuropathic pain conditions. These are part of the complexity of chronic pain, but they do not normally mean that additional physical harm or injury has happened. People with painful chronicity, including those who are terminally ill, are also vulnerable to sleep deprivation, financial and social anxieties. Level 3 pain clinics provide detailed assessment, group education on self-management and specific therapies and strategies for improving quality of life and mobility and family life with chronic pain. Level 4 services may be offered by palliative care physicians, and these can include interventional techniques where there is need, for example, for a patient to receive a spinal cord stimulation or slow delivery of local anaesthetic. I'd like to finish by pointing out that it's important that belief in the patient's complaint of pain is a guiding principle of pain specialist care. Not being believed is the most commonly reported and detrimental complaint that people with unexplained chronic pain report when first seen by a specialist pain physician or specialist pain staff. Helping the individual develop self-management skills for their long-term pain is another principle. Now, important also to point out that self-management does not mean being abandoned by healthcare professionals, nor is it merely a last resort when all else has failed. All self-management approaches are based on the belief that the person with pain or any long-term health condition has a crucial role to play alongside their healthcare team in the management of their condition. So it's the healthcare team and the person with pain and their family who can all gain sufficient understanding and education about how to deal with different aspects of the chronic pain presentation. Self-management has good results. It helps to increase well-being and to reduce disabilities induced by the pain, and in so doing, it very often modifies the pain itself. Now, just a final thought. It's worth knowing that people with long-term health conditions spend, on average, just 3 hours a year with their healthcare professionals. And it's therefore important to have ways to cope with the other 8,762 hours in the year. And that's the importance of self-management skills for pain. They help us to do that. Now, in summary, the chapter I've written, I hope, helps to give an understanding of differences between acute and chronic pain, and in so doing helps us understand what to expect from the treatment and outcome. Although pain is complex, perhaps all-encompassing and hard to bear, specialist services for pain are available that help to cope with living or dying with pain. My chapter includes an appendix which gives details about levels 1 to 4 pain management sources in Scotland. It has to be said that these sources have, to some extent, been affected by COVID. However, they have resumed by and large and should be able to include patients who contact. For example, patients living in rural areas of Scotland can now be referred to Scotland's residential unit for chronic pain, which is the Scottish National Residential Pain Management Programme in Gartnavel Royal Hospital in Glasgow. Once again, I do emphasise the importance of the third sector organisations, particularly Pain Concern is the main national charity, supplying online resources. Referral from a healthcare professional is not required, but can give all sorts of very important information about the complex and different aspects of living with chronic pain. Thank you.